I welcome all of you to the BCBR session on validity of an epidemiological study organized by Dr. B.R. Ambedkar State Institute of Medical Sciences, Mohali. I am Dr. Maneesha Sharma, Professor and Head Department of Anatomy at AIIMS, Mohali. So what are the points we are going to discuss today? We'll be discussing about internal and external validity, what is accuracy, different types of errors like random and systematic errors, types of biases, causes of these biases, and how to deal with them. Let's first see what are the goals or objectives of an epidemiological study. Basically, the epidemiological study aims at accurately estimating the frequency of a disease and also estimating the accurate association between the exposure and the health outcome of the study participants. Both these things together constitute the internal validity of a study. And if after getting the results we can extrapolate these results onto the target population, it will be called as external validity. So basically validity is of two types, internal and external. If we get accurate results of a study, it will be called as internally valid study, and if those can be extrapolated to the general population or the target population, it will be called as externally valid study. We can understand this from this diagram. Here we can see this is the target population. We have taken a sample from this target population and we have subjected it to a particular study using different methods and different stages of the study, reaching the conclusion and the results. And if those results are accurate, we will call this study as internally valid. And if we can extrapolate or generalize these results to the total population, it is called as externally valid study. Now, what is accuracy? Accuracy has two components, that is precision and validity. What is precision? It's getting the same results if we repeat the study using the same methodology. It can be called as reliability. And validity is getting the right results without error and bias. So if we see this diagram, here we can see the results are at one point. We are getting almost the similar results on repetition. So, but we actually wanted to reach or target this bullseye. And these results are indicating that they are repeatedly coming the same, but they are very far off from the bullseye. So this study is indicative of that the results are precise, but they are not accurate. Here we can see the results are less precise, coming at separate points, but still they have better accuracy. They are closer to the bullseye. In this diagram, you can see the results are precise as well as accurate. We are getting almost similar results and that too accurate. We can take an example to understand what is reliability and validity. If suppose we are going to measure the calcium levels of a patient, which are actually the value is 10. If we keep on repeating the tests on the same patient, we get these values like 8, 10, 10, 11, 9. The test is said to have good reliability and good validity because if we see the values are closer to the actual value and they are also repeated. If same test is repeated in the patient and we get the values like this 15, 16, 14, 16. So these values are closer to each other but they are far off from the actual value. So that is why this test has a good reliability but poor validity. So validity of a study can be affected by errors which can be of different types, like random errors which are called as chance errors, which can be sampling errors and measurement errors. And another category is systematic errors or biases. They are the more problematic ones. In these errors, basically the process is faulty, which tends to produce results systematically departing from the true values. We can understand it like random errors are the chance errors, and the single values are scattered and are around the mean value. If we take single value that may be far off from the mean value, that is the validity. But when we take the mean value, it is closer to the actual value, or it has a more validity. But whereas the single value is having high uncertainty. Whereas in systematic errors or biases, what happens is all the values are shifted away from the actual value. So even their mean is also not valid. So that leads to low accuracy of the results. So biases which can affect the validity can be classified into selection bias, information bias, and confounding. So there can be another way to classify the bias. It can be either subject bias or information bias. Subject bias can be further attention bias or Hawthorne bias and recall bias. Attention bias is when the study participant tries to change or eliminate his behavior, usually seen in cohort studies. Recall bias is that cases are able to recollect more regarding their exposure status as compared to the controls. Investigator bias is further off selection bias, information bias, and interviewer bias. Selection bias is when we do not select the sample properly. Like if we select the cases from a hospital, it will be called as Bergsonian bias. Information bias is that we are concerned more about getting information from the cases as compared to controls, or detailed information from the exposed than the non-exposed group. Similarly, in interviewer bias, the interviewer may prepare a questionnaire which is leaning more towards the cases or the exposed group rather than controls or the unexposed group. Selection bias can be further classified into different categories. Like there can be sampling bias. The sample is not true representative of the target population. As we can see in this figure, here we can see three types of people in this group. One are the ones with are having disease and with symptoms. Another are with disease, no symptoms. And third category is without any disease. When we have drawn the sample, we considered only two groups, with disease and symptoms and with disease, no symptoms. But the third category has been left out. So this sample is not the true representative of the population. Similarly, another category of selection bias can be non-response bias. That is, we selected the people who will respond to our questionnaires, but they have not responded, leading to wrong results. Like another is Bergsonian bias, already described. We are taking cases and controls from hospital setting rather than from the general population. Another is prevalence bias, where we tend to miss the patients who have not survived, and we are considering only ones who are suffering and are alive. Another is attrition bias, where during cohort studies, during the follow-up period, the patients tend to leave the study, or the ones who are exposed, they tend to leave the study, thereby leading to attrition loss. Now, how to deal with this selection bias? We can deal with it during designing stage. We should try to use incident cases, not the prevalent ones, to eliminate the prevalence bias. In case control studies, the cases and controls both should be taken from population rather than from hospital settings. Same eligibility criteria should be considered for cases and controls. They should undergo same diagnostic procedures and same degree of surveillance. During data collection stage also, we can try to select the selection bias. How? We should try to minimize the non-response, non-participation and loss to follow-up. We should try to maintain the data of even the ones who are lost to follow-up so that we can compare it later on. We can go for the blinding of the study participants or the investigator and analyzer. So single, double or triple blinding in cohort studies will help to deal with the bias during the data collection stage. During analysis stage also, we need to compare the responders with non-responders, and we can use the study results and compare it with the external information like reviewing the literature, and we can assess whether there is any bias and what is the direction and magnitude of that bias. The other category of bias can be information bias. So one I already mentioned, that information bias can be due to the investigator, or it can be due to the subject or the study participant involved. The investigator may be more inclined towards the cases. He may be taking detailed history of the cases, and the questionnaires in cohort studies may be more detailed for the ones who are exposed to certain factors which are being studied. So that will result in information bias. Or there can be bias due to the behavior of the study participants. When they know they are being watched, they can intentionally, systematically distort the facts, which is known as prevarication. So the information bias usually results from the faulty procedures used to measure exposure, outcome, and other variables. As I have already mentioned, that the questionnaires or the degree of investigation may be different, that results in information bias. Now, how to deal with it? We should properly define the operational variables, and the measurement protocols should be available in detail, so that while taking any variable there should be no confusion to the investigator. Similarly, we can go for repeated measurement of the key variables and then take an average of the values. Similarly, the ones who are involved in the study, their training and certification is must. We can go for data audits, data cleaning, and we can rerun the analysis before we go for publication of the results to avoid any information bias. Another bias is confounding, derived from confusion of effects. What happens is, confounders are some extraneous factors which can affect both the exposure as well as the outcome, and can bring out different association between the exposure and the outcome. So we should be very much aware of what can be the effect of confounders. So confounders can simulate an association between an exposure and an outcome. They can hide an association between them. They can also reduce the degree of association between an exposure and an outcome, and can enhance the association between an exposure and an outcome, and can also reverse the association. Like suppose we are thinking of that smoking is the factor which is under consideration as exposure, and we are seeing the effect of smoking on lung cancer. There can be some confounders, like age can be one of the confounders, which is not indicating the exact relation between the smoking and the lung cancer. So there can be some other factors also which act as confounders. We should be aware of them. Now, how to deal with confounding? During design stage, we should try to limit the study participants to one stratum of the confounders, which is called as restriction. Then for cases and controls, we should try to match them regarding various confounders. If we suspect that certain factors can act as confounders, we should try to match the cases and controls according to those confounders. Then there can be randomization, which is usually done in experimental studies. During analysis stage, we can deal with confounding by using stratification and by doing various types of analysis, that is multivariate analysis, which can be either regression analysis, which can be linear, or logistic regression analysis. So this is how you can deal with it. So how can we conclude that there is actually an association between an exposure and an outcome? Suppose we have studied something and we have come to know that there is some relation between these factors and this outcome by taking an odds ratio or risk ratio, and then we go for a study find the true causal association, we should keep in mind the random error. We should try to rectify as far as possible. Then other biases, which as already discussed, the biases which can be selection bias, information bias and confounding. So looking into all these factors and trying to eliminate them so as we can reach the true causal association between the exposure and the outcome. So for every study, we should be able to understand what can be the possible biases in that study. We should try to avoid as far as possible. And if some of the biases cannot be avoided, these will be considered as limitations of this study. So that's all. Thank you very much.